Oxygen administration. This is one that we tend to have a lot of difficulty with. Even when you get out in the field after you graduate, there's still a lot of trouble with oxygen, and I don't know if it's because we aren't you guys aren't respiratory trained, so you don't come across it that much. We also become very desensitized as sleep techs to people with low oxygen levels because we watch it drop throughout the entire night. So when we have somebody that has a low oxygen level, we tend to minimize its significance or its potential detrimental consequence in our head. But this is something that will keep coming back up, that we're going to keep revisiting because it is so important. The principles of it, the safety of it, how to make sure that we are recognizing an emergency situation when it presents itself to us and that we are responding appropriately. I think part of the disconnect as well is because in Patty's class, she talks PaO2. She doesn't talk a lot about SpO2. And so she relates these very severe scenarios with a patient's PaO2 level. And we don't oftentimes readily have that information available to us, but we very rarely do, because our patients these are oftentimes outpatient testing sites, so they don't even have the ability to do an ABG. We have to go by the patient's SpO2. So what I want you guys to take from this is that we do need to be able to respond. We need to recognize an emergency situation when it presents itself to us, and we need to know how to respond appropriately and take the right measures to respond. In pharmacology, we talked a lot about the fight or flight response, but there is one response that we don't talk about, and that's freezing. Typically when you guys get scared, or anybody, we tend to, just humans in general, when we get into a situation where we are presented where we're nervous, it's fight, it's flight, or it's freeze. So what I wanted you guys to do is kind of just hammer it in your head to respond, to do something when we are presented with a situation like this. So more and more you will see oxygen is necessary for some patients in the sleep lab, even if we're doing a CPAP titration. Sometimes our patients have these, they're pretty sick where they will still need supplemental oxygen to maintain their SpO2 levels. Typically, we don't add supplemental oxygen until their respiratory disturbances are corrected. So for instance, what that means is if the patient's oxygen level is low and we know why it's low, because it's an apnea, because it's a hypopnea, because they're having all these respiratory disturbances that we typically see during the night, then do we put oxygen on them, or do we treat the low oxygen at its source? You treat the respiratory disturbances first before seeing the need if you need to add supplemental oxygen. Because if you were to add supplemental oxygen, it's just like throwing a Band-Aid on a severed artery. It's not going to do much. You're not doing what you need to do in treating it at its source. And one of the other things, the reason why I'm also really stressing this, I'm going to keep bringing it back up because sleep has evolved. When I first started working in sleep, home sleep testing really wasn't done all that much, if at all. And with the big surge in home sleep testing, now you aren't seeing those, typical overweight dude, middle-aged, fairly healthy otherwise, straightforward OSA CPAPper, right? All those patients, the very straightforward patients, are now being tested with home sleep tests, so we don't see them as much. And what we are seeing, the population of patients that we're seeing in the sleep lab, they are sick. They are a lot sicker than they ever were before. And so our ability to recognize that and respond is more important than ever. So how to look at SpO2 values and relate it to what you're learning in Patty's class. So your typical PaO2 levels and how it translates to what most likely their SpO2 level is. Okay? So mild hypoxemia is an SpO2 between 91 to 94. We also in the sleep world tend to just kind of generically think anything that's above 90 is good. It's above 90, we're happy. But mild hypoxemia is to have a SpO2 of 91 to 94. Did you know that? Yeah. So again, we tend to become desensitized to it because also we have what's known as nocturnal dipping. So when we fall asleep, our SpO2 levels naturally drop by about 2% from what they were awake. So that means we're able to more tolerate lower SpO2 levels. We're not going to jump right in and throw oxygen on a patient with an oxygen level of 94. It's honestly pretty good. But based on this scenario and the patient's history, in an otherwise healthy person, an SpO2 level of 91 might make you think, wait a minute, what's going on? Why is their SpO2 91? Generally, SpO2 of 92% is considered the lowest clinically acceptable level, with the exception of about 88% in chronic lung disease. And I think also we're going to see those values change. There are new things being published about being able to tolerate lower SpO2 levels in these very chronic, and these sick patients, these chronic lungers, COPD, that type of thing. All the patients that you're going over and learning about in Patty's class. Hypoxemia is when low oxygen levels become low. Hypoxia is the consequences that occur when a patient is hypoxemic, when they have low oxygen levels. So some possible causes of hypoxemia would be either they have a limited FiO2 even available to them. Room air is what FiO2? 21%. At higher altitudes, the partial pressure of the atmospheric gases change, and the available FiO2 in the room air becomes less, which is why you have that altitude-induced hypoventilation and all these changes in breathing respiratory disturbances that can occur at higher altitudes. If the patient has problems with gas exchange, so hypoxia, your patients that are emphysemic, COPD, they have a change in at the level of their lungs where they have difficulty releasing CO2 and absorbing oxygen. If they have a low concentration of hemoglobin, so an instance of that would be patients that are iron deficient and anemic. Their body doesn't have the ability to carry that much oxygen to the tissues. If they have, their body has a lower affinity for hemoglobin, of the hemoglobin for the oxygen, like in carbon monoxide poisoning. So in that instance, carbon monoxide takes the place of oxygen. The hemoglobin can't bind to oxygen, and that's why it's such a fatal and very serious situation when you have somebody that has carbon monoxide poisoning. Overall, though, we should know that a normal SpO2 or a normal oxygen saturation is absolutely vital to maintain normal, healthy functioning of all our tissues in our body. So the symptoms of hypoxemia, the number of symptoms that you see, and the severity of them really depend and relate on what the patient's SpO2 level is. In moderate hypoxemia, you might see that they become tired easily, they might be lightheaded, they might feel a little numbness or tingling in their extremities, they might become a little bit nauseous. And these are all symptoms that we can easily, think about in your own body, how we very easily kind of write off the severity of symptoms. Like, oh, I'm not pregnant, I'm just nauseous because I had a bad breakfast. Like, we can so easily validate things in our head, and I'm not pregnant. I'm just using that as an example of something that I don't have a stomach, I don't have the flu, it's just, Our patients do that to us. They do it all the time. I don't need to go to the hospital, just, let me sit here a little. And that's where it's up to us to respond and react appropriately. And almost, I'd rather in any sense see you overreact. I'd always see you err on the side of caution than have that oh shit moment of, well, that escalated quickly. I probably should have reacted. Basically, anything beyond moderate hypoxemia, the patient usually will start exhibiting symptoms of hypoxia and having these negative detrimental consequences of their low SpO2 levels. So again, hypoxia is what occurs in response to hypoxemia or low SpO2 levels. And what can happen is when it becomes great enough or severe enough, you will start to see cellular damage and then cellular death. Cyanosis is a good indicator that the patient is experiencing hypoxia. So cyanosis, where you start to see the blue extremities, and you'll first start to see it in their fingers or the lips. That's where you want to look. And when you see cyanosis, that is an indicator of you have a medical emergency on your hands. Do not listen to what the patient's telling you of, oh, this is my normal, I'm fine. And no, when you have a patient that is cyanotic, you have an emergency situation on your hands automatically. When hypoxia becomes severe, it can cause the patient to have twitches. They might become disoriented. They might experience hallucinations. You'll start to really see their color become quite pale. It might start affecting their heartbeat. They might start having arrhythmias, and eventually they could die from it. And the scary thing about hypoxia is that it typically has a snowball effect, and that once it's started, it will just speed up and deteriorate very quickly, where you need to start to be able to recognize these more minor symptoms and respond to your patient before it becomes a situation that's out of hand. So this is an example of what cyanosis looks like in the tissues, and the fingertips is where you'll first start to see it. Always, when you see that, medical attention, always. Nothing that we are doing is so important that it would warrant not having the patient err on the side of being safe to just go to the ER, get checked out, let's make sure everything's good. We can do your sleep test another night. There's nothing that we are doing in the sleep lab that is so important to put off potentially life-saving medical treatment. Should I say that again? It's like an outpatient test. It could get done at any time. We're open 6 nights a week. Whatever. We'll do it at another time. Go to the emergency room. I've listed some signs and symptoms of hypoxemia, and they're listed in about the order of when you start to see them. So you'll see their respiratory rate, tachypnea, will start to increase to try to make up for the low oxygen levels. They might complain of feeling out of breath or dyspneic. You'll start to see their color be a little quite pale. Their heart rate is going to increase to try to pump more blood to their tissues to try to make up for the low oxygen levels. Take their blood pressure. This is why, I always harp on you guys about maintaining your skills and basic vital signs, because while it's not necessarily done in most labs as a routine part of the intake process, when you need to be able to do it, you need to rely on those skills that you still have them, that motor memory, because you're going to be so nervous. You need to be able to fall back on the motor memory of just being able to take a blood pressure and to palpate a heart rate to make sure it's accurate and all of that. They might complain of headache. They're going to start to feel anxious. You might start to see cyanosis. And then this is where you start to get those snowball effects, and where it ultimately starts to become, it could be fatal. Anything on this first part of the list, you are reacting. So some signs and symptoms of chronic hypoxemia, so this would be your chronic COPDers, your chronic lungers. They might have arrhythmias, reduced cardiac output. Clubbing is when you look at their fingertips. So look at their fingertips. It'll tell you so much, not only in their color, but when you start to see clubbing. Clubbing is when you start to get it's literally their fingertips club out. Like they get these widened kind of clubbed fingertips. But anytime you see anything in this first list, I want to see you respond. And more often than not, your patients are going to tell you not to call an ambulance. Don't call for EMS. Well, we don't have refusal forms in the sleep lab. The EMS do. They can refuse the EMS once they've arrived. We've done our due diligence. Myoclonic jerking, so like the jerks. Another symptom of chronic hypoxemia would be papilledema, which is a lot of pressure in and around the brain, which causes swelling on your optic nerve, pressure on your optic nerve. So this can cause vision changes. It can cause them to start to see black spots. That's the cause of that. Also with a lot of vision changes, it can cause the feeling of nauseous. Like how many times have we had these vision changes and it causes us to feel nauseous? Polycythemia would be elevated number of red blood cells, which means that the blood is too thick. So these patients are at increased risk of blood clots, heart attack, that type of thing. When we have a patient that's hypoxemic, when their SpO2 level drops below a certain level and typically stays there, again, it's normal for our patients' SpO2 levels to drop when they have an apnea. It's not normal for it to stay low. It needs to come back up in between the apneas. There needs to be a recovery. So sometimes supplemental oxygen is needed, and sometimes it's needed emergently. Like you need to respond quickly. Overall, treating the underlying cause is the primary goal of treatment, but oftentimes it's out of our hands. If it's OSA that's causing their apnea or their SpO2 to drop, that's an obvious one. Treat their apnea. But if it's some underlying lung disease, anything like that, that's not our scope of practice. That's something where we need to put the Band-Aid on it while they're in your care and get them off to where they need to be to get the proper treatment. A typical instance of oxygen delivery, though, in the sleep lab is with a nasal cannula, and we do have the ability to titrate oxygen just like we do with CPAP. You know, we're changing the CPAP level to try to figure out what works best for the patient. We can titrate the oxygen as well to try to figure out what's going to best treat this patient. As always, I can't stress enough documentation and verification with your medical director, because oxygen is a drug. You never want to just apply it indiscriminately, and we always need an order for it. There's certain situations where labs will have policy and procedures in place where it's almost like you have a standing order to apply it, but that still doesn't work around the fact that you need to verify it with the medical director and just make them aware that a situation is happening in their sleep lab. So goals of oxygen therapy is to relieve hypoxemia. Let's get their SpO2 and PaO2 levels up, decrease the work of breathing, and decrease the work of their heart. As a review, we're looking at their FiO2, or their fraction of inspired oxygen. It's expressed as a number from 0 to 100. So 100 is 100% FiO2, means that they're breathing only oxygen. FiO2 of room air is 21%, or 0.21. As with most things, there are potential hazards of applying and using oxygen. Oxygen is a fire hazard. It does support combustion to make a fire burn more hotter and more rapidly. Dave Teniak has some really good pictures of beds that have burned up where patients in the hospital are trying to sneak a cigarette, so they'll tent themselves underneath a sheet because it's hidden. They're hidden that way with their supplemental oxygen on, and the result when things catch fire of the beds, just they're gone. There's also what's known as oxygen-induced hypoventilation. Basically what that is when you have a patient that's a chronic lunger, they chronically have elevated CO2 levels in their blood, it changes what initiates their drive to breathe. Normal, healthy people, you and I, our drive to breathe is based off of our CO2 levels in our blood. When your CO2 levels are chronically high, those chemoreceptors start to become blunted and non-responsive to elevated CO2. And instead, the drive to breathe is based off of the oxygen levels, or PaO2. In these patients where their drive to breathe is based on their PaO2, then we give them supplemental oxygen to raise their oxygen levels up. You can knock their drive to breathe out. There's also what's known as oxygen toxicity. Doesn't happen very often. Usually when patients are given a really high FiO2 for a prolonged period of time, this is something really that they have to be mindful of for like the neonates and stuff in the hospital, making sure they're judicious with what oxygen level they're putting the patients on. Oxygen is a drug. You don't want to use it indiscriminately, but you also want to make sure that you are responsive when it's necessary. Things to be avoided when there's a patient on oxygen is anything where they're smoking, so lighters, vape pens, anything with oil, because again, that can support the combustion. So there's certain commonsensical safety rules that have to go into effect if you have a patient on oxygen. There has to be no smoking signs posted or oxygen in use signs posted. So if there is a smoking section nearby, people know to make sure they're careful with that. Obviously, all electrical devices should be grounded. That should be something that's done regardless, and most buildings are hopefully built to code where your outlets are grounded, so all of our electrical devices are also grounded. To apply supplemental oxygen, you do need a prescription for it. Again, some labs have policies where you can go ahead and initiate supplemental oxygen administration, and they will supply the order afterwards. It's kind of like a standing order. But for the most part, you need to call the physician. Even though you have a policy and procedure in place that says, if this is the scenario, go ahead and put on oxygen at this level, whatever, call the physician, because when you get into these scenarios, typically you're working with a very sick patient, and I don't want to knock their drive to breathe out if they're breathing on a hypoxic drive. I don't want to do anything negative. I always want, and that's kind of the nice thing about not being a physician, is I don't make those decisions. I don't get paid the big bucks to make those decisions. They do, and they're on call for a purpose, and that's to verify, get the backup. Number of years I worked for St. Pete's. The physicians there are so phenomenal. And even if we did have policies and procedures in place, their specific personal policy was to call them. Because oftentimes, even though they would take the specific patient in mind before making that decision to apply oxygen or not. And there were certain patients where they met protocol, we can put on oxygen, the physician chose not to, because of this patient's history, because of the other comorbidities going on. And so I just documented. I called the physician, this was their outcome. And then typically too, the docs, they care, otherwise why would they be in this profession? They're calling me if anything changes, they're calling again in the middle of the night to check in on the patient. They know first thing when they walk in the building in the morning, they're going to check on that patient and follow up and do what they need to do. I've also worked at a lab where I'm thinking in that mindset where the person wants to be aware of what's going on, and I called the physician, and they seemed annoyed. Well, didn't seem. They were totally annoyed with me calling them at 8 o'clock, 9 o'clock at night. You're getting paid for this. This is your job. Yeah, I'm going to call and verify that your patient that had a major heart attack 3 weeks ago is complaining of chest pain and doesn't want to go to the ER, and it already called her physician. I'm going to call. I'm going to verify. So always call. Always err on the side of being safe. I'd rather annoy them than not, and have that scenario of, man, I wish I was aware of this situation as it was happening. The supplemental oxygen prescription, things that are required. It either needs to include how much oxygen you're putting on, so either in liters per minute or based on what specific FiO2 they want to be delivered, because certain devices you can hone in a specific FiO2. how you're going to be delivering it, so what device, either nasal cannula, mask, bleeding it into your CPAP machine, other very patient-specific considerations that you might do. And if we do have the ability, if they want us to titrate oxygen, what parameters do they want us to titrate it to? What SpO2 levels should we titrate up to? All of that. So if supplemental oxygen is warranted, your medical director must be notified. You have to get a verbal order from your medical director for the supplemental oxygen. If you don't have an order in place at the start of the test, sometimes you are lucky, you'll walk in and you'll know the patient needs supplemental oxygen. You'll have the order ready to go. That never happens. So we need to call. We need to get a verbal order from the medical director, and they will replace your verbal order with a written one in the morning. Things to be included is who you called, that's important, what doctor, your date, the time, and anything else they want, so that what the SpO2 range that they want the patient to be, like maintain an oxygen saturation greater than 89%. Make sure that you read back and confirm the order, because there's a lot of parts to doing an oxygen order. There's a lot of components that you need to get. You need to make sure that you get it right, especially if it's greater than or equal to or greater than, those little things. Make sure you verify and sign it with your name and credentials. So the specific scenarios of when we would add supplemental oxygen is if the patient's SpO2 is 88 or below while they're breathing room air. And that includes if it's less than 88 for more than 5 minutes in the absence of obstructive respiratory events. This first scenario relates more to when you have a patient that just came in you look like they're short of breath, they're breathing heavy from just the exertion of walking across the parking lot. Throw a SpO2 probe on them, catch their vitals. You know, you don't have to wait until like, oh, this is the order of the procedure when I get their SpO2. Throw one on them. Evaluate your patients whenever you see that it's clinically indicated. And so you need to let them also sit for a little bit. It needs to be more than 5 minutes that their oxygen is staying sustained at a level that's considered to be hypoxemic. The second instance also is more for the scenario that your patient is having obstructive sleep disordered breathing. So they're having obstructive respiratory events. If that's causing their SpO2 to drop and stay dropped, then you first need to treat why their oxygen is dropping in the first place. So treat the apnea at its source with CPAP, BiPAP, whatever. And then if their oxygen continues to be at a level that's hypoxemic, well, that's a reason of why, unrelated to their apnea, that would be an indication to add supplemental oxygen. If patients are on supplemental oxygen already, they're on home supplemental oxygen, they sleep with 2 liters at night, they use 2 liters during exertion and at night, then we need to keep the same for when they're in the sleep lab. They should be on their prescribed oxygen liter flow, unless if you have a physician order that says to not use it. So this last one is one of these really fun little instances where a patient says, you see it in their chart, they're on home oxygen. Regardless, you need an order then of whether you are going through with oxygen and continuing their oxygen at their home level, or if you're withholding oxygen. You need a physician's order regardless in this scenario if they're on home oxygen. Or an even more fun situation, or also a very common one, is when the patient met with the sleep doctor and had their initial office visit, 3 weeks ago, 4 weeks ago, whenever, and the time between when they met with the sleep doc and when their sleep study was scheduled, they met with the pulmonologist and were then put on home oxygen. And they didn't think to call the sleep doc and let them know. They're just telling you as they walk in. Yeah. The AASM, American Academy of Sleep Medicine, protocol for supplemental oxygen during your PAP titration. You need to add supplemental oxygen if the patient's awake supine SpO2 level while breathing room air is less than 88%. and their SpO2 is less than 88 for more than 5 minutes if they're not having obstructive respiratory events to account for that low SpO2 level. Which means that when your patient first arrives and you do a quick spot check of their SpO2, it's not just slap it on their finger, you get a number. You need to leave it on there, and you need to observe and let them sit for a few minutes, upwards of 5 minutes, to figure out where their oxygen is, where it should be, if it's going to come up after they sit for a little bit. The minimum starting oxygen flow rate should be 1 liter per minute. That's regardless of whether you're dealing with an adult or a pediatric patient. And when we are titrating oxygen, you're going to increase in increments of 1 liter per minute. So no half a liter, quarter liter, none of that. 1 to 2 to 3. You're going by full numbers, waiting at least 15 minutes between each change before increasing the flow rate again. So you're giving the patient at least 15 minutes to acclimate to whatever oxygen flow that you just applied before making the judgment call to either increase it again or leave it as is. Typically, you're titrating your oxygen upwards to try to achieve a saturation level between 88 and 94. And again, this is where you need to get your physician's order, because sometimes they will want a higher SpO2 level in certain circumstances, or they'll tolerate a lower SpO2 level in certain circumstances. So that's where you really need to make sure that you're verifying with your physician what level or what SpO2, the minimum they want you to shoot for when you're titrating your oxygen. If you reach 4 liters per minute, if you've applied 4 liters per minute and the patient is still hypoxemic, make sure you check the validity of your equipment, that it's connected, it's working properly, before you keep going up higher. For the most part, the majority of circumstances that we see in the sleep lab, unless if it's an emergency situation, we're able to resolve the patient less than 4 liters. So when you keep going up higher than that, you really do need to make sure your equipment's functioning properly. The problem with supplemental oxygen on a sleep study is that it can mask the effects of a patient's sleep disordered breathing. Part of their diagnosis and being able to look at the clinical picture of the severity of their apnea is seeing how low their oxygen levels drop and how long do they stay there. What percentage of the night do they spend with their oxygen in an unhealthy range. So when we have a patient that's on supplemental oxygen, the severity of their apnea will be masked. It could also mask the patient having hypopneas, because what's part of the definition of a hypopnea? A desaturation. And if you don't have that desat, their RDI is going to be erroneously low compared to what it actually would be if they weren't on supplemental oxygen. That's one of the reasons why you want to titrate your CPAP or BiPAP first to try to correct their obstructive breathing, and then add oxygen if necessary to further increase their SpO2 levels out of hypoxemic ranges. Okay. Within the sleep lab, we will use the equipment pictured to be able to what's known as bleed in oxygen to your PAP machine. So it's connected at the level. You need your flow meter, a little Christmas tree to connect the tubing. This is what's known as a T-piece connector to connect in the supplemental oxygen and make it part of the circuit of the CPAP. So pictured, what you see is you'll have the oxygen tubing connect from your flow meter to your machine. The tubing connects to your little T-piece, and then it gets delivered to the patient. That's a little Christmas tree to connect the tubing. This is what's known as a T-piece connector to connect in the supplemental oxygen and make it part of the circuit of the CPAP. So pictured, what you see is you'll have the oxygen tubing connect from your flow meter to your machine. The tubing connects to your little T-piece, and then it gets delivered to the patient. That's a little bit more of a close-up to it. So the reason why you connect your T-piece here and not at this end is so that, A, you're delivering a more consistent FiO2, because this tubing is 6 feet long. and it has 6 feet of tubing then to consistently, the air that's being delivered from the PAP machine and the supplemental oxygen that you're delivering has 6 feet of tubing to mix, and so you have a more consistent FiO2 being delivered to the patient. And then the other thing is, if you connect this little T-piece up here, you have more up and around the patient, more that they can get tangled in, more that they could accidentally disconnect by taking a hard turn, and you wouldn't have any idea until you start seeing their SpO2 levels drop. And it also delivers a less consistent FiO2 because it's delivering right up here where it immediately gets mixed with the room air before getting delivered or before the patient breathes it in. Again, you don't want to connect the T-piece to the mask because you're delivering a much more variable FiO2, and the patient could easily just, they take a hard turn, disconnect that, and you wouldn't really have any idea. It's not like the cameras we use are just so high quality you can zoom right in, The other thing you need to watch out for is the increase in central apneas, meaning supplemental oxygen can knock a patient's drive to breathe out. You'll see it mainly in patients that have COPD, the chronic obstructive pulmonary disease, emphysema. And if that happens, if you start to notice an increase in central apneas after adding in supplemental oxygen, you need to decrease back off on your oxygen rate so that way they're breathing, you're not knocking out their drive to breathe. That's a really good indicator they have a hypoxic drive to breathe. There's also been instances where we can wean supplemental oxygen. I've had plenty of studies done that way, where the physicians want us to start, the patient's on 2 liters of home oxygen or 3 liters, whatever, do your titration with them on 3 liters, but once you get their apnea settled, then see if you can't back off and wean the oxygen off to see how they are. And that's more being a lot more careful with the patient. We're not allowing their oxygen to really drop at all in the first place. So one way that we can try to decrease their oxygen level is to utilize BiPAP instead of CPAP. So last week we talked about CPAP, BiPAP. CPAP is continuous positive airway pressure. They're getting one pressure that they're breathing in with and they're breathing out against. BiPAP is 2 different pressures. So there's an inspiratory pressure and an expiratory pressure. What we can do is try to play with that IPAP, EPAP, or inspiratory-expiratory split to try to kind of increase their IPAP even further above the EPAP to really augment their tidal volume that they're breathing in to try to get their SpO2 levels a little bit higher. The problem, though, one of the things you do have to watch out for is when you increase your PAP levels, PAP is just room air. And so when we talk about the principles of FiO2 and entrainment, what happens is when you have a CPAP of 5 and you're delivering 2 liters, the FiO2 that they're receiving is higher. When we increase the CPAP and we keep the oxygen at 2 liters, we're entraining more room air and giving them more room air with each breath, their FiO2 starts to go down. Does that make sense? Okay. So that's one thing you have to be mindful of is as we increase the PAP, the overall FiO2 that's being delivered to the patient goes down because we're delivering a lot more air. We're entraining a lot more room air. Whereas if we back off on the PAP, they're receiving the higher FiO2. The most common circumstance of why we see low SpO2 levels in the sleep lab is obstructive sleep apnea. OSA is our bread and butter. It's what's going to keep us employed. So one thing to be mindful of is oxygen should not be a replacement for PAP therapy. When you have a patient that has OSA, supplemental oxygen is not the recommendation for treating at low SpO2 levels. Because again, low SpO2 levels in response to a patient having obstructive breathing, that you're just putting a Band-Aid on something. You're not treating it at its source. There's different mechanisms for how supplemental oxygen can be delivered in the sleep lab. Sometimes you'll see it delivered via cylinders. Oftentimes you'll see it with a concentrator. It might also be liquid, where it's piped in through the walls, so you just have the wall outlet that you're using. But just know the universal color code for oxygen is green. So when you look at the wall flow meters, or if you're looking at the tank, they'll have a green band on them, or they'll be green in some way. Room air is yellow, but green, that's what you need to remember. Green is oxygen. Cylinders, you'll see there's a lot of different sizes of them, and they're typically named with a letter to delineate what size cylinder they have. Oftentimes in the sleep lab, we only have large cylinders, and they're acting as more of a backup if the concentrator were to fail, or the piped in weren't working, or we needed more than what those modalities were able to deliver. Patients will come in on the smaller sizes because those are portable, but there's not a lot that can be housed within these cylinders. So the important thing to remember is to, as soon as they get to the sleep lab, turn off their cylinder, check that it's turned off, and switch them over to whatever modality we have available in the sleep lab, because the last thing you want to do is have them using their own oxygen, that tank to run out. Then what are you sending them home on? What are they doing on the drive home? What are they using for the drive home, right? Regardless of the size of the cylinder, a full cylinder has a pressure of 2,200 psi, which is a lot. It can make it like a missile. So we're going to talk about cylinder safety. And then the other thing too is every cylinder needs to have a valve on it to be able to reduce the pressure of the oxygen coming out of the tank to a workable pressure, to about 50 psi. Those are the reducing valves that you'll see on the top of the tanks to make them usable. Otherwise, it's just, you got a missile on your hands. When a patient arrives with a portable cylinder, you really need to take care. Turn off their cylinders immediately. Store them in a place that they're away from any heat source. Also make sure they're in a place where they don't fall. So don't just set them on the edge of the bed where they could roll off, because again, if they were to fall and to break and you were to hit that valve just right, you can Google it, you can YouTube it, but they have become missiles. They are very dangerous when not treated properly. So make sure, I always store them on the floor, and I tuck them underneath the bed so they're not a tripping hazard. We know where they are. If they don't, some of them come in and they've got like the little rolly cart for it. They've got the stand. Those are safe in and of itself because it's holding it upright. Just put it in a place where you're not likely to bump into it or the patient's going to trip over it. Make sure the cylinders aren't stored in a small, unventilated area, because you will have a little bit of seepage coming from those tanks, where any venting oxygen could create a fire hazard. They need to be secured in a stand or a cart at all times to make sure they don't fall over. If there isn't a stand or a rack available, store it lying down where they can't present themselves as a tripping hazard or something that they could easily roll off of. Again, the weight of it alone, because these things are pretty heavy, the big ones, you're not moving, you're not lifting up on your own. Good luck on that. That's a huge part of learning of the respiratory curriculum is cylinder safety and rolling them and making sure that you are supporting them and that you're not going to drop it. The other thing that you'll find is you have to crack the tank. Yep, that's one of the things we always had to carry with us, was a screwdriver or a wrench. So before you put on the valve on the tank, you had to crack the tank a little bit to let air come out the hole and then close it back up. And that will clear any dust or debris that might have gotten into the ends. Because you've probably seen the trucks, right? They truck them around in the open air. It's just loud, very loud. You're not doing anything wrong. But again, these can become very dangerous if handled improperly. Make sure all oxygen equipment, including the tubing and the cannulas, are kept at least 10 feet away from any source of heat, and you're strictly enforcing the no smoking policy. And pretty much every hospital now is a non-smoking campus. But the problem is a lot of sleep labs are in off-site, in like office parks and stuff. Those are not non-smoking campuses. So patients can smoke. And I've had patients on supplemental oxygen say they're going to go out for a cigarette, and I've had to step in and be like, well, let me have the oxygen back. You're not going outside with that. Never use grease, oil, or other petroleum products anywhere near oxygen equipment because they really could be a further fire hazard. Your flow meter. So this is the tool that you're going to utilize to be able to adjust what level of liter flow the patient is receiving. And it's needed for most forms of oxygen, whether it be via cylinder or the wall outlet, the liquid oxygen. And the most common type you'll see is the Thorpe tube. This needs to be upright. When you put this into the wall, which you're going to learn how to do, you put it in the wall, you need to make sure that it's fully upright because you're using, you're going to go by like a little ball to figure out where the ball is floating, what oxygen flow they're receiving. And if this is askew, if you have it askew, it's not going to be accurate. Oh, that's what I just said. Another common way you'll see oxygen delivered in the sleep lab is with a concentrator. Basically what it does is it pulls in room air and concentrates the oxygen in room air to deliver it to the patient. It's a lot more convenient. They are safer. They're less expensive than tanks. But you are limited with the maximum liter flow that can be delivered with this. Typically these things max out at 4 or 6 liters per minute to be able to deliver to the patient. The other thing too is they're loud and they can really heat up a room. So when I have a patient that I need to put supplemental oxygen on, what I'll try to do is get enough oxygen tubing to get this thing outside of the room and put it outside the door and just kind of like tape down the oxygen tubing on the floor so it's not a tripping hazard. And that way too I can make my adjustments on the oxygen flow level without having to go to the patient room, without having to wake them up, but it keeps the noise of it out in the hallway and it'll keep the heat of it, because otherwise you're going to be dealing with a lot of sweat artifact with these patients because you go in that room and it's going to be boiling because this machine can really heat up a room. The other thing that you should be familiar with is how to analyze oxygen. That's one thing that we'll do is calibrate all of our machines. It's part of the QA that we have to do, quality assurance, is do an oxygen analyzation to make sure that the FaO2 being delivered, these machines are working. These oxygen analyzers are very simple. You turn it on and you first want to calibrate it to room air, make sure it's reading at or around 21%, and then you hook it up to whatever oxygen delivery device that you're using and test it to make sure that it's delivering the FiO2 that it should be delivering. There's other high flow systems. So there's different types of systems that you'll see patients on in terms of how they receive their supplemental oxygen. High flow systems meet the patient's entire inspired volume of air. So they're not breathing in room air at all, where it's getting delivered all for them. Not really typically seen in the sleep lab. Typically what we'll see is the low flow systems. So they partially meet the patient's inspired volume, but the patient's also breathing in room air. So like your nasal cannula that goes in the nose, it's partially meeting what they need to breathe in, but if you were to only breathe in what's being delivered by the nasal cannula, you'd be pretty air hungry. You're also breathing in room air. And it often requires humidity because it can get quite uncomfortable without it, but it's not necessary. You can use it without it. So some of the high flow delivery devices would be a non-rebreather mask, an air entrainment mask. The non-rebreather is what you'll see in emergency situations. It's the mask that goes over the patient's nose and the mouth, and it's got the reservoir bag. And so the premise of this is that the patient is breathing in entirely what's being delivered by this mask. Theoretically, then, that they are receiving an FiO2 of 100%. They're uncomfortable, and fit determines performance. There's a one-size-fits-all. They come in two sizes, adult and pediatric. Now look at all your faces. We all have different shapes and size faces, and so it's never going to seal perfectly on any one person's face. There's 3 one-way valves, one here and here and here, so that the patient isn't supposed to be breathing in any room air. The one here prevents the patient's exhalation from entering into the reservoir bag. The reservoir bag is entirely filled from the oxygen source. And we need to turn the oxygen, the flow rate on your flow meter up to at least 12 liters per minute. But again, when you're using one of these devices, it's in an emergency situation. You'll typically just turn it all the way up, just totally up, to just totally meet the patient's needs. Because fit determines performance with these masks, they are realistically, patients on this will receive an FiO2 of about 70%-ish, because it's not going to fully seal. They're going to be breathing in some room air with it. The low flow delivery devices that you'll possibly see is the ones we'll go through. First one's nasal cannula. Nasal cannulas deliver a flow rate of anywhere between 1 to 6 liters per minute. Higher than that, it can get very uncomfortable. They're not recommended for higher than 6 liters per minute. And again, one of the things that we'll do in lab is you'll feel what it feels like to be on high flow with a nasal cannula and how uncomfortable it is. With nasal cannula, we can't deliver a precise FiO2, but you can approximate about what they're receiving. So if you have a patient that's on a 1 liter nasal cannula, they're about receiving an extra 4% FiO2. So you would start at 21 and add 4. So if somebody's on a 1 liter, they're receiving an FiO2 of about 25%. 2 liter, 29%. 3 liter, 33%. Make sense? There's a lot of advantages with nasal cannula. They're very easy to put on the patient. They're disposable. You throw them out. You don't clean them, reuse them. Patients are quite compliant with these because they're so minimal and they're easy to put on. They're quite comfortable. And they do come with conserving devices, because the problem is what happens when you exhale and this thing is delivering a constant flow of oxygen. It's getting wasted. So those are the tanks that you might see where they have the little tss, tss. Have you ever heard those? That's the conserving devices. So it's only delivering oxygen during exhalation, shuts off during exhalation. You might also see that they have these little reservoirs to catch the air that's being delivered during the exhalation phase, so the patient gets a little bit more of the supplemental oxygen when they inhale. Disadvantages are that it is somewhat of a unstable device in that you can't really deliver a precise FiO2. So if the physician needs the patient to receive 30% supplemental oxygen, a nasal cannula isn't really the way to go. It can also cause a lot of discomfort in the nose, cause sinus pain, irritation, in severe cases nosebleed, which is one of the reasons why humidification is preferred. When I immediately, as soon as you put a nasal cannula on me, my nose burns immediately. I need the humidification. The function of it is also affected by a patient's ability to breathe through their nose. So what happens if they have deviated septum, or if they have nasal polyps that could be obstructing their nasal passages, or if they're really secretious, they've got a runny nose? You're not going to be able to get in the amount they're supposed to be breathing in. And what happens when they start breathing through their mouth? What happens to their FiO2? Yeah. Again, we can't estimate this patient's mouth breathing, so this is what their approximate FiO2. There's none of that. You just got to kind of take it with a grain of salt. A transtracheal oxygen catheter, I have this in here because you might see it. It's not anything that you are going to apply, but it's for some patients that are on long-term supplemental oxygen. It would be surgically inserted into their trachea to deliver low-flow supplemental oxygen, and it typically is conserving because it's getting delivered directly into their airway. Another low-flow device would be a simple mask. This would maximum flow rate is between 6 and 10 liters per minute. You have to have the simple mask on at least 5 liters a minute to at least flush out the patient's exhaled CO2. Otherwise, what you'll see is when they exhale into the mask, you get a lot of their exhalation getting built up in the mask. So you need to have the flow rate at least 5 to 6 liters to just flush out what they're exhaling into the mask. But the mask itself acts as a bit of a reservoir to catch the supplemental oxygen that's being delivered and during the exhalation phase. The approximate FiO2 that the patients are receiving when they're wearing this is anywhere between 33 to 55%, and it's only a short-term device. This is not utilized for a patient that's on long-term supplemental oxygen. This would be in the instance of, say you have a patient that's on a nasal cannula and you max them out. Nasal cannulas, you can't go any higher than 6 liters a minute. That's when you might be able to jump over to the simple mask until you get them situated with where they need to be. Because for the most part, if you're the one titrating and you get up to 6 liters and you're switching over, you're calling 911. That's like, okay, what's going on with this patient that this is beyond out of our scope. These masks are uncomfortable. The fit determines the performance. How well the mask is sealed to the patient's face will determine how much FiO2 they're receiving. You have, with anything that covers a patient's mouth and their face, you have the risk of accumulating CO2. So we could actually do more harm than good in these patients. You know, these are the patients that need to be breathing increased oxygen. If we don't have the flow rate high enough to flush out the CO2 that they're breathing out, they're rebreathing their own CO2, and we could be doing more harm than good. Does that make sense? And with anything that covers the patient's mouth, you have a risk of aspiration. What happens if they vomit with this mask on? Anything that goes over a patient's mouth, you always have to have that in the back of your mind, including CPAP masks. Another type of mask would be the partial rebreather. This is very similar to the non-rebreather that we just talked about. It's just you remove these one-way valves, which means, so non-rebreather means that they're not rebreathing any of their own air. The non-rebreather mask was supposed to theoretically deliver 100% FiO2. Partial rebreather, when we remove these valves, the patient is allowed, some of their exhalation is allowed to go back into the reservoir bag. And with these valves off of the mask, they are allowed to entrain some more room air. So what happens is we can put them on less of a flow rate, but the bag should still not collapse more than a third, but they are receiving less of an FiO2. So between 35 to 60% estimated. Partial rebreather, non-rebreather, again, they're the same mask. It's just you take out these little one-way valves. That's it. So the patient's not receiving as high of an FiO2. With the mask, the fit is not perfect. Again, you have 2 sizes, pediatric, adult. It's not tailored for all the different shapes and sizes of faces that are out there. You always run the risk of aspiration if the patient were to vomit. And if the oxygen were to become disconnected, it's a lot bigger of a problem than if you had a nasal cannula on the patient and it were to become disconnected. Do you know why? They're going to be rebreathing, all their own CO2. And we're going to do a lot more harm than good in that scenario. Versus a nasal cannula, they naturally can just breathe around it. It's not really obstructing their breathing in any way. Does that make sense? So let's return to how to connect PAP masks to an oxygen lead-in. Some of the older style masks have these little ports where if you were to pop that up, you can connect the oxygen tubing directly to the mask. Again, it's not preferred to do it that way, even if you do have a mask on that's got that little port, because you're delivering a very invariable FiO2. The risk of the patient disconnecting that is a lot greater. So what you want to use is the T-piece connector, which is connected at the PAP device, and then you connect your CPAP hose to this. Allow the patient 6 feet of tubing for the supplemental oxygen to mix with the room air, so they are receiving a more precise FiO2. The majority of situations of when we see supplemental oxygen in the sleep lab, you're either bleeding it into the CPAP or it's a nasal cannula and you're titrating it. Only in emergent situations would be throwing on the non-rebreather or partial rebreather. Your role when you have a patient on oxygen is pay attention to them. Don't ever hesitate to call for help. I'd rather see you err on the side of being safe than sorry. And you should always be monitoring your patient, whether it be pulse oximetry. Not a lot of labs have the transcutaneous oxygen monitors, so keep that pulse ox on them until you transfer their care to emergency personnel. Do your vitals on them, spot check them, heart rate, respiratory rate, blood pressure. You should understand everything that we just covered in terms of the concepts of oxygen therapy, potential detriments of applying supplemental oxygen, the equipment that you're using when you apply supplemental oxygen, and make sure also you're following up with the lab protocol for where you're at, because every single lab is slightly different when it comes to this. So always take care of your patient first, but follow back up with lab protocol to make sure that you did everything that you needed to do. You called everybody that needed to be called. And the other thing to remember is no flow, no go, which means you are not putting a mask on a patient's face that doesn't have oxygen coming through it. If you have a patient that is having trouble breathing and trouble oxygenating, you're not putting something on them and then turning the flow up. You need to turn the flow on and then you put it on. So always in the back of your head, no flow, no go. Same thing with CPAP. You're not putting a mask on the patient and then turning the machine on. You're not covering a patient's breathing with anything without having flow coming through. Should I say that again? Do not obstruct your patient's breathing by putting anything in their nose, over their mouth, without having flow coming through, whether it be CPAP, oxygen, or anything. When you take it off, you're not going to turn the machine off and then take the mask off, or turn your flow rate down and then take the mask off or the cannula off. You always take it off the patient first and then turn it down. No flow, no go. Do not ever have anything on the patient that's going to obstruct their breathing when they're already having trouble breathing and oxygenating, to then have to, I don't know where I was going with that sentence. But you get what I'm saying, right? This is one of those things too that we cover. We're going to cover all of this again in lab, because I know a lot of it is hard to understand until you actually get your hands on it and you're feeling what I'm going through as well. You're gonna try them all on. Cannulas, masks, put together, the CPAPs, all of that. So tell me what's wrong with this picture. The location of your T-piece connector. It's connected at the mask versus at the machine. So the patient's getting a less precise FiO2, easily knock it out. And let's go through some case scenarios. So you're reading through your patient's chart, and prior to their arrival to their coming in for their overnight sleep study, and you note the following. They have a history of COPD. The patient reports in their chart that they feel out of breath when walking short distances. When they came in during their initial office visit, their SpO2 was spot checked at 88%, and there's no mention of home supplemental oxygen use. Does this patient qualify for oxygen? No. The only thing when you're reading through a chart that would qualify the patient for oxygen before they walk in the door, before you've had the chance to evaluate them, is what? A history of being on home oxygen. So should you call the physician at this point for an order? No. Don't, because the first thing they're going to ask you is, okay, well, how does the patient look? What's their vitals? Just spot check their SpO2? And you're going to look like a dumbass because, well, no, I'm just reading the chart. But they're not even here yet. So the patient arrives for their overnight sleep study and mentions that since their initial office visit, that's IOV, with the sleep doc 3 weeks ago, they saw their pulmonologist who has prescribed supplemental oxygen at night and during exertion via nasal cannula. So what should the next step be? Before you call the doctor, evaluate the patient. What's their room air? What's their SpO2 at the moment when they walked in? Were they on supplemental oxygen when they walked in the door, or do they only put it on right before they go to sleep? What's their heart rate? What's their blood pressure? Evaluate the patient. You need more data. At this point, does the patient qualify for oxygen? Yes, they do. But your first step should always be, all right, let me evaluate the patient. Let me check their vitals. Let me see where they're at. Do you know what needs to be included for the physician order for oxygen? Date, time, doctor's name, who you called, what, yep, FiO2 or liter flow, or what your target SpO2 should be, how we're going to put it on them, yeah, you're not just going to blow it in their face, your name, credentials. So once you have a valid physician's order, what's the next step? Take care of your, well, we already did the set of vitals before we called the doctor. Put it on them. Take care of your patient. Yeah. So here's an example of what should be included in your valid physician order. You have the date, the time, and the ordering physician's name, overnight PSG, and you see how it's actually written out, like in a sentence, so it makes sense. You're not just 2 liter, O2, like abbreviating things. You actually write it out. So as per Dr. Snooze, overnight PSG to be performed for 2 liters of supplemental oxygen via nasal cannula. So that one sentence has the physician's name, your liter flow, and how you're going to apply it. You read back that the order, you read back and verified the order, your name, your credentials. You actually need to write it out. You need to actually write it out so it's legible and makes sense. Don't just, we get in the habit of just jotting down things quickly. Like, write it out in a manner that is understandable. We're going to go through another scenario. You're reading through your patient's chart prior to their arrival for their overnight sleep study, and note the following information. You have a male, 64 years old, and his history is strongly suggestive of OSA. He had knee surgery that required hospitalization. He has a history of asthma, allergies, hypertension. He's taking several medications, including an inhaler for his asthma and pain meds related to his knee surgery. Does this patient qualify for oxygen? No. Should you call the physician for an order? Well, it's still early in the night, though. Should we call them and just have maybe a standing order in case, so we don't have to wake them up later on in the night? The answer is no. They're going to say, why are you calling me during dinner now? When you're going to be waking me up later. Your patient arrives for their overnight sleep study and appears to be somewhat out of breath from the exertion of walking in from the parking lot into the building. What should your next step be? Sit them down. Take their vitals. Monitor them for several minutes. If you just spot check their SpO2 after they've exerted themselves, does that qualify them for supplemental oxygen? How long does their SpO2 level need to be? 5 minutes, which means you're sitting with them, you're monitoring them, you're staying with them and monitoring their SpO2 level, spot checking their respiratory rate throughout the time, spot checking their blood pressure, doing all of that. Does the patient qualify for oxygen at this point? No. Don't fall down the rabbit hole. From what information you have right now, does he qualify? That's the thing with the boards, too, is it's really easy to start following this rabbit hole of, well, but if, and da-da-da-da-da. You have to look at the information at what's presented to you. With this information, Patient is dyspneic, out of breath from exertion, does it qualify for oxygen?
Yeah.
No. Despite being indicated, oftentimes physicians will choose to go without supplemental oxygen so as not to mask obstructive respiratory events on the baseline PSG. So regardless, sometimes when you have a patient that's dyspneic and they might qualify, you're still going to call the physician and they might say, no, I want to go without it. I want to see how they do. Call me later if it gets bad. Because supplemental oxygen can lower the AHI by not allowing the desaturations to occur in order for a respiratory event to qualify as a hypopnea. And the severity of the desaturations is part of their OSA diagnosis. I mean, we go by RDI to determine severity criteria, but they also look at the general picture of the patient's history and other factors. What about the severity of their desaturations? Was it causing hypoxemia? So if you call the physician and oxygen is being withheld, you still need to document that. Here's how this documentation may look. So you've got the date and the time. Patient arrived for his baseline PSG and appeared out of breath. Obtained patient's vital signs. Called Dr. Snooze to determine how to proceed. As per Dr. Snooze, baseline should be started without oxygen and will call Dr. Snooze again if any other issues or concerns arise. And because we're all extra, 20 minutes later, reassessed patient's vital signs after he was sitting down and resting for 20 minutes. Follow back up on the patient. That goes back to like our first day, one of our first talks about documentation is you're not just doing it to do it and like, okay, I did my assessment, I'm done. I can check that off my list. We're in healthcare. Follow up on your patient. Reassess their vitals 20 minutes later. Case scenario number 3. You're reading through your patient's chart prior to their arrival for their overnight titration and note the following information. It's a titration, which means they've already had a study done. They've already been diagnosed with OSA. Their baseline study demonstrated that the patient had severe obstructive sleep apnea with significant desaturations. His baseline SpO2 on his previous study was 87%. Patient's a smoker and has a history of emphysema. Does this patient qualify for supplemental oxygen? No. What's going on here? Significant desats, low baseline.
All those things usually are normal.
Yeah, but we don't have the ability to say that. But they're typical side effects of somebody that's got severe OSA. So what's the number one thing we want to do? Treat the OSA and then see if there's still an underlying hypoxemia related to his history. So should we call the physician for an order? Not even for like a standing order in case because of his history and what he did on his baseline? Typically no. Typically no. And usually the physicians, they'll say, no, just call me later if he qualifies. They want to be aware. Sometimes I have gotten a standing order like that, though, where based on what they did, based on the patient's health history, based on their titration results, you start the study without oxygen, titrate, and so that order might look somewhere along the lines of start study without supplemental oxygen, titrate and treat obstructive events first. If necessary, add supplemental O2 via ASM standards or something like that. Where you have a standing order, so in the middle of the night, should they qualify because you've gotten them titrated and they're still hypoxemic, then you can go ahead and add supplemental oxygen without having to call the physician because I already have my order in place. But usually, you might not know all this. And most often, most of our patients were able to do what we can without supplemental oxygen to get their oxygen up. Your patient arrives for their overnight titration study and you complete an initial evaluation of their vital signs and their SpO2 is 90%. What should your next step be? Yeah, we could keep monitoring them and continue the study as ordered. Continue on. Does the patient qualify for oxygen at this point? No. As the night continues on, you increase your CPAP level incrementally from 5 centimeters of water pressure upwards to 14 to eliminate the obstructive respiratory events. After a CPAP level of 12, you note that all respiratory events have been eliminated, but the patient's SpO2 is still only 86%. What should your next step be? You can call the doctor, or what? Yeah, but we would need to call the doctor for that. What's another thing we could try? We already tried increasing their CPAP level above therapeutic to see if we couldn't get their try BiPAP. Yeah, that's what I would do. I would try to switch them over to BiPAP and see if I couldn't give myself a little bit of time playing around with the IPAP-EPAP split, see if I couldn't get their tidal volume up just enough to eke them above that hypoxemic level. In so doing, I've eliminated them from needing 2 pieces of medical equipment in their home, to costs, to upkeep, a lot of upkeep maintenance, and now they're only down to the 1. I would try it, you know. I'm monitoring them. If something were to happen, I can see it. Yeah.
So even after...
Does the patient qualify for oxygen at this point? Yeah, they do. Typical, here's an example of what the physician order for an oxygen bleed-in would look like. You've got your date, your time, the physician's name, how you're applying it. So as per Dr. Snooze, apply supplemental oxygen via T-piece bleed-in to PAP at 1 liter per minute. Titrate supplemental oxygen via ASM standards to maintain an oxygen saturation above 89. So the ASM titration standards are: you start at 1 liter per minute, wait at least 15 minutes between each change. Once you hit 4 liters, check all your equipment. And it'll typically have the oxygen SpO2 range between 88 to 94. But again, this is where, based on this patient's history, the physician chose above 89, which means you're going to 90 or greater. So make sure that you are actually verifying and reading back the order. You can't document it if you didn't do it.